Oh, that's beautiful. How exciting. All right, wait, start in and don't do such a great job that my stuff is going to be boring.
And I don't think I have ever had a meeting open with 200 people constituting a quorum. Thank you, everybody, for your presence here. Thank you for sharing time with us. Carol and I are so very excited by the reality that the state has submitted a modified waiver amendment to the federal government. The feds, as we expected, have accepted that proposal, and the federal comment period is now live. And so we thought this would be a wonderful time for all of us to reconvene and to orient ourselves with a level set and shared understanding of what this modified document looks like. So I'm going to yield to Carol, who's going to do agenda review, and then I'll come back with additional remarks, and Carol will take us into the heart of the forest. And then hopefully we can do this in such a way that we have left ample room for open discussion, and we invite you through the course of our time together to, as you have done at the last such forums, use the chat log to zip to us questions that you have, concerns, comments, so that we can capture them, and as part of the meeting documentation, we'll make sure all that stuff gets out to all of you all in the open space we try to continue to protect as we've made this journey today. So Carol, let me stop talking. I'll hand it over to you and you can kick us into gear, my dear friend.
Okay, and I think the overall message is Carol has to hustle through her slides. So just real quick, I like how people are putting their name and organization in the chat. That's very helpful, so you can do that. As Wade said, we will share the presentation. We will talk a little bit later. We're going to be setting up a site where all of the previous materials from the previous forums will be on, the FAQs. We will be doing another FAQ based on the questions and the chat questions. Also, it is being recorded. So if there's anything spicy that you want to say it offline. Okay. All right. So our agenda for today, we'll have Wade kick us off in his wonderful way. I will do a quick refresher of the waiver, not too much. I know a lot of people have already seen and heard a lot of this already. We can have you reference previous documents for all of that history, and the actual link to the waiver will be on our new site. I'll go through high level, very, very high level, the major points that changed from the draft proposal to this proposal that was finally submitted to CMS, that was accepted is complete, which is different than accepted. It's accepted as complete. There's going to be negotiations that go on from here between CMS and New York State. Then we're going to talk about what happens next, what the timeline looks like, and what we're doing in our region. And then we're going to open it up. So it's going to be fast and furious. Put your seatbelts on, get your caffeine and your lunch, and let's go. Wade, kick us off.
I'd happily do so, Carol. And friends, those who have had the displeasure of having to hear me talk lately know that I'm in a Beatles mood. And my thoughts are of the long and winding road. I've seen that road before. I have been in partnership with so many of you for decades, and I know that challenging times that require innovation, times that really require unleashing the power of the community, that road always leads me here. And thank you all for opening your door to us as we have this conversation today. For the sake of time, I'm going to be real quiet and Carol is going to present. Otherwise, we'd have you all here all day. But let me say to you, I spent yesterday with my 83-year-old mom who just got discharged from ICU. And in my family, we don't consider this sharing HIPAA protected private information. We consider it to be testimonial service, how it is that we share our experience with each other and we learn and we engage collectively in order to meet the challenge. So as we say in my faith tradition, those of you who know the word of prayer, say a prayer for Mary Lou Norwood. But my mom said to me yesterday, she said, and yesterday was my mom's mother's birthday. And I officiated my mother's funeral, both here in Rochester and down in Homerville, Georgia. And my mom said to me that she is surprised that she's lived to be 83 years old. Because she said, wait, you know, we don't live to be this old. And as the armchair genealogist for my family, I know she's telling the truth. There are very few people in my family who reach the age of 70, let alone 83. And Mom and I were talking about, why is that the case? And she knew instantly, access to education. The first generation in the family to have an education beyond high school. She knew wealth. She said, wait, it had everything to do. This is why we moved y'all out here to Henrietta. Because to move from 14611 as one of the zip codes with the highest rate of premature mortality to 14586 created a very different environment in which her children lived, learned, loved, and grew up. And so I am super aware of the fact that health improvement is absolutely tied to all of those things we now call the social determinants of health. But back when I left government that came into this, we just said it's the stuff that really matters. And that's what this waiver is all about. How do we find the investment will to pay for the things that really matter? Something as small as a dear friend donated to me the shower chair that her mom used to use. It's how we care about each other. And that's where you guys not only come in, that's where you lead. That's why the long and winding road leads to you all. And we understand very well that our charge is you are absolutely already powerful. Our job is to make sure you have the knowledge, the information and understanding, and the opportunity to do what you do so well, which is impact the system and impact for good the lives of our neighbors. Carol, I'll stop talking there and I'll hand it to you. Please take us away, my darling. And when you're done, feel free to pass the plate.
I will. Thank you so much. And I'm so excited to have everybody here. This is just amazing, the interest in this waiver and in this work. And I thank Wade Norwood for being at my side and partnering. Common Ground Health and FLIPS will be partnering on co-leading this waiver. And we're really, really excited. It is about partnerships and collaboration across the entire community. And I wanted to really quickly talk about what this waiver is about, as Wade always so eloquently describes in stories. And this is about reducing health disparities, advancing health equity, and supporting the delivery of social care. And it's three simple things that are so complex. And this is how the state has really narrowed down their overall goal. They've kind of switched things up as far as goals versus strategies, but this is their overall goal. And they actually have renamed the waiver. And so if you recall, it was a convoluted name that originally was noted as SHERPA, Strategic Health Equity Reform Payment Arrangements. It's pretty sterile and boring. And now they're calling it the New York Health Equity Reform, NYHER, which really speaks to the state's commitment that this is about health equity. anybody who had the privilege of being on yesterday's CCSI 30th anniversary Zoom event heard Pulitzer Prize winner Andrea Elliott talk about her book, The Invisible Child, and her following the story of Dasani and her family through Brooklyn as a child she met in a homeless shelter. And it was a riveting testimony to this work, the health aspect of this work that really is the social care aspect, that really touches the education aspect, that touches the lives. And so while I go through this, and I can't speak as eloquently as Wade, just remember when we go through the mechanics, when we look at these words, when we look at these silly graphics, that it's really about those families. And as you know, you are all the ones, the direct providers that work with those families, and we are the helpers. And so thank you for going on this journey with us. Okay, so this slide should look a little familiar, except for the name change. It's still around health disparities, integrating social care and health care. The dollar amount is still 13.5. I added a 2 this time because you know what, we're talking about billions of dollars. So that 0.52 really makes the difference. And again, I want to remind everybody that these are incentive dollars. This is a demonstration project, and we are still, New York State is still targeting January 1st. Okay, so this slide should also look familiar. These are now strategies. They were originally goals. Now they're strategies for the framework of the waiver. And the main points here around each strategy are as follows. So the first strategy has all these fancy words, but really this is around the structures that the waiver is going to support, the HERO, the SDHN, which you heard in past presentations, the value-based payment models, capacity building for providers, who the target populations are, adding criminal justice in particular, which really hasn't been touched in previous waivers. So that's what that first strategy is about. The second strategy is about housing. And you'll notice that they changed this from supportive housing to transitional housing. So they're being a little bit more clear and specific on the definition, really focusing on the homeless and long-term care population. The third strategy is really focused on the financially distressed hospitals and nursing homes and workforce. Again, major theme in this waiver, and we are all feeling it. And the fourth one is what I call the technology strategy, and this is where your digital health and telehealth support is referenced. Okay, so this is going to assume that you were part of previous presentations. And so again, we will be publishing in one place all of the previous presentations and of course the actual waiver link. So you will be able to go through it and refresh yourself on the details. So what we're going to talk about here are just the changes, the high level changes. But where I wanted to start is where we left off, which was back in May when we polled the community and we pulled everybody together and we drafted a community response to a public comment request by New York State. The major themes that everybody rallied around were these. We wanted community-driven and flexible implementation. Kind of don't tell us what to do. You can give us some guardrails, but we really kind of know our region. We've got a lot of infrastructure here that we've already built. We've been collaborating for many years. Allow us to kind of design things ourselves. Leveraging existing assets and infrastructure. The geographic region, we're going to talk about it a little bit, was a big sticking point for us because the state defined the Finger Lakes region very differently than how we define it. A lot of feedback around supporting community-based organizations, a lot more. Transparency, flexibility, and development of measures. A major focus on children and families, which was not referenced in the waiver. That was a big sore point for not only our region, but other parts of the state as well. Where are the special populations, the targeted populations that you state had put in your original concept paper? They were gone. And then focusing on prevention. So these were kind of the combination of things that we sent, many pages with many logos. And I'm very pleased to say that the state listened. The state listened to the feedback because our region had such a great showing of feedback. They really listened to us, and they also incorporated many of our suggestions. So really pleased with that. It just shows the impact that our region and how big we are has on the state. This is a slide from a United Hospital Fund conference back in July. Wade was invited by the United Hospital Fund to talk about regional planning in our region. And I had the honor and pleasure to be invited by Wade, along with Laura Gustin and Anne Marie Cook as the chair of the RIO, and Laura Gustin as the lead for Together Now, also known as Systems Integration Project. And I think we had a great showing to that audience about how we do work in our region. At that meeting, Amir Basiri, the Medicaid director, showed the slide, which showed all the feedback that came to the state and the relativity of that feedback. So really the font shows how much feedback each of these categories received. And so you'll notice child and maternal health, especially workforce, housing, a lot of questions around HERO and SDHNs. And so when the state turned around with their final proposal, you'll see a section that talks through questions and answers around a lot of the feedback. Actually, I found the questions and answers section to even be more indicative of what the state is thinking than the actual final proposal itself. So the message here is they listened. All right, so let's start at the top on what has changed. As it relates to health equity, they're really underscoring, as I said, health equity as the goal, adopting it as their formal goal, and they defined equity. And the definition of equity is coming from this Robert Wood Johnson quote. And this is in response to the fact that people were asking, what do you mean by health equity? We really need a common understanding of what that means so that we're all across the state marching toward the same goal. So that's the first kind of prominent change and clarification. The next thing that changed is clarification around what key groups will be included in the HERO. And the state received a lot of feedback around populations that weren't referenced, who's going to be included in the HERO, who's not. And overall, the response from the state was, we identified certain populations, not to the exclusion of others, but more as examples of which populations are included. So the state went back and they specifically called out these particular groups, children and families, tribal nations, consumers with lived experience, older adults, pointing out that, hey, this is our illustration of examples. Each region will, based on their needs assessment, identify what are those populations that need to be at the table, and what are those populations that we need to focus on based on the needs assessment. What does the data tell us? And so the second piece then, there's two pieces, right? Who's going to be involved in the HERO, and then who should be the focus of our interventions. So the state wanted to clarify that the words that they were using and the examples that they were using were really illustrative and not defining necessarily. There will be definitions, and we'll make sure we'll address those, but our region should be able to, through our analysis, our collective analysis, identify where we need to target our initiatives. Next is around this notion of evidence-based versus practice-based. And that's something that was brought up more than once in the public comments, and specifically by our region. Yes, we know what evidence-based practice is, but in the social care space, we have not had an opportunity to prove things out because we did not have the dollars to put toward data collection and put toward data analysis to prove things out, to provide that evidence. But we do have promising practices, and we do have what we're kind of calling practice-based evidence. So state, you know what? Don't make us just do evidence-based practice, because you're going to limit us and you're going to limit innovation. And I love Laura Gustin really did an eloquent job of pointing this out in her public comment. And the state really listened. And so this is a big win, I think, for the CBOs in particular, where we're not going to be pigeonholed into just evidence-based practice. This is going to allow for innovation. Focus on prevention. This is something that Common Ground Health in particular called out right off the bat, right when the waiver came out. You're not connecting this to the community health improvement plans. There's a lot of focus on that and a lot of effort, years and years and years. How could you disconnect that from this work that you're doing? And so they put that in, they called it out. And again, mentioning childhood, children and families, and specifically ACEs, which is really important. So I want to again thank Anne Marie White, Dr. Jeff Kazarowski, LJ, Dr. Shipley, and Larry Marks for the great work that they did in advocating for children and families to be referenced in this waiver. Criminal justice involved, they did expand the conditions for that population to be able to qualify for pre-release services and get connected to Medicaid earlier. Another piece relates to funding, and additional funding will be going to social determinants of health networks, CBOs and networks. The VBP incentive pool will use a fee schedule to pay CBOs. This is what I had anticipated and what I presumed and what I shared with all of you. Thank God, that's kind of what the state is landing on, because I was very concerned that the advanced VBP models were really just kind of so confusing. And, you know, we're not going to start there. We have to start with fee schedules for community-based organizations and just pay straight fee for service, fee schedule for the social care services. So this is a good thing that that was clarified. More funding, again, for the SDHNs, which is the capacity building and back office support to be able to support an infrastructure that is the network of community-based organizations. And really importantly, the state said, you know what, those CBOs that cross lines, cross geographic areas, you don't have to just be part of one SDHN. I added this slide back in, this is a slide that I had in the original, I think the number 2, which I got a lot of good feedback on from people that this kind of helped people frame how these social care services might be paid. So I thought I'd throw this back in for your reference. The waiver calls out the North Carolina Healthy Opportunities pilot model, and I think I told you I chopped it up and I kind of created like a little mock fee schedule here just to give you an idea of the thinking that the state has. They like this model, and so this would be where they might be going on how they would support fee schedule development and or eventually per member per month payments for social care services. All right, a little bit more on VBP. Now, I just want you to know the VBP section is very complicated, very comprehensive, and very detailed. This slide does not do justice to that. So if you want to do a deep dive, please read that section. Also, we would be happy to kind of do off kind of general community forum education sessions on the VBP section, because it gets sticky. But at the highest level, they're calling out that the quality measures will include stratification by race and ethnicity, and there will be optional measures for other subpopulations. So that's kind of at the highest level. They do call out more examples for value-based payment for the behavioral health population and those providers, as well as FQHCs. For FQHCs, they're talking about APMs, which are alternative payment models, and they are really still hammering home this notion of global payment models. And they've put more detail in that definition and what they're looking for with global payment models, as well as more detail on payment bundles. So there's a lot behind this slide. I'm not going to go into it because that's a whole separate conference that, of course, we will, probably put together as we proceed. But I wanted to make sure you understood that there is more detail in the waiver about value-based payment. Very importantly, around the social determinants of health area, the state has decided to not select a social care closed loop referral IT platform. In the original proposal, they had said that they were going to do a procurement process to select a statewide platform, and people were concerned about that because we have different things across the state. In our region, we have a couple of different platforms. So this is good news for our region. Pleased that they listened to the feedback. And what the state said instead is that they're going to leverage the SHINY, which is the statewide real platform for referral and social care data collection, and have that as a repository. And that would be used, of course, to share amongst the RIOs and the entities. And so this is good news for us because it, again, gives us flexibility to leverage the work that we've already done in our region with Together Now and My Wayfinder, for example, and the 360 network and other platforms that might be out there. So, however, the platforms that are used across the state do need to be screened and qualified by the state for interoperability. So that is kind of where their guardrails landed. And the state will be selecting a uniform social needs assessment, which is interesting. I think they're really trying to standardize as much as possible across the state. So we're getting a little bit closer to customization at the regional level with still kind of a state standardization where it makes sense. All right, geographic regions. This is the priority for me and Wade. The geographic regions, if you recall, the brown area is how they define our region, and we know better. We've been operating on the flip side, 13 counties. Common Ground Health also has Skylar. So we believe this is how we've been operating. These are our natural care patterns. These are where our anchor health systems are. These are where our CBOs cross lines. And this is how we've been doing business. This is how we collaborate. So Wade and I have prioritized that this is how we're going to advocate with the state so that there is a recognition and not an upending of all of the structures that support this model of a region. Okay, so I know I'm probably going very fast and not fast enough for Wade and Albert, so I am going to go a little quicker here. All right, our region. This is the same slide with a few little tweaks that I showed before. We are very well positioned. We have heard from other places that we are ahead of where other parts of the regions of the state are in our planning and discussions and collaborations. Obviously, our ingredients make for a really prepared effort, a collaboration, just evidenced by the number of people who are on this call. We've got a commitment to racial equity. There's so much work that's already being done, community engagement. The counties are engaged. We've got strong regional planning, robust existing infrastructure with FLIPS and Common Ground Health and United Way and CCSI and Together Now and 360 Network. I mean, we have so many infrastructures that support the partners, and we are all sitting at the same tables and we are collaborating. And so that is how we need to move forward. This is not about building a whole nother PPS or building another planning agency or anything. This is about partnering across those organizations and networks with our associated FLIPA, HP, and GRIPA, who are the VBP entities, and really understanding how we can change things and do business differently. We've got a proven track record in our region that we can just only build upon. Okay, so what do we need to do? We need to continue meaningful participation of the community-based organizations to scale innovation, cultural responsive services, trauma-informed care, and really focus on the state's goal around eliminating disparities and improving health outcomes. Meaningful engagement of the MCOs, I reported the last couple of times, that is a big change from how we used to do business. The managed care organizations will be at the table, part of the hero, and because of the VBP dictate, will be a meaningful part of the conversation. It is not going to be easy, but it's necessary in order for there to be sustainability on the other side of this waiver. Ongoing evaluation and other mechanisms to ensure accountability. We know everybody is very concerned about accountability. How is the money going to be divvied up? How is funding going to happen, who's going to get what, who's going to be represented, et cetera. So we will need to build in evaluation and accountability. And we've done a lot of that work in other initiatives like Together Now, for example, where there has been a concerted effort for human-centered design and accountability, shared accountability. Leveraging and building on an existing infrastructure and really getting those infrastructures together in a more meaningful way and partnering in a really different way, formally and weekly. And so I'm really excited that, we have been working together for a while now, and it's just going to get these relationships, it's going to make these relationships stronger. Okay, so what can you do now? A couple of things. Networks, and this is similar to what we've talked about in other forums. What network are you part of? Who are your partners? What are your referral patterns? On the health equity and social care, how are you supporting health equity for your clients, for your patients? How do you do social determinants screening? What are the services that you provide that are improving health outcomes? What are the new people, new partnerships, new organizations that you might need to partner with? On the workforce side, oh my God, we could all write a book on the challenges here, but we need to really articulate that in a way that makes change, that calls for understanding what the gaps are, and especially in the community-based setting. There's been a lot of talk around the clinical setting, but we really need to focus on the community setting and what are the workforce challenges, what are the regulatory barriers, scope of work, et cetera, and what are the training needs, what are the challenges, recruitment, how do we create that pipeline, how do we build on the work that we've already been doing in workforce in our region. Stay informed. Okay, I'm not going to tell you to read the 82 pages of the waiver, but at least flip through it. And this is a trick. I always go into the find. I put in a couple of keywords so that I can, identify what the state is saying about things that I'm interested. And that's kind of how you might be able to go through it. Highlight it where you can, ask questions in the margin so that we can have a conversation about how are you interpreting things, how are we interpreting things, and collectively we can get a shared understanding. Participate in whatever network you're part of, participate in those conversations, ask questions, continue to participate in these forums so we can keep you up to date, and also bring to your board at least a high-level understanding of this waiver, what it means to your organization, how does it impact your strategic planning, how can it be part of your strategic planning? It shouldn't change your strategic plan, it should actually enable your strategic plan. Understanding your value, what data do you collect, how do you use that to change how you do business and prioritize your business? How do you measure impact? How do you evaluate your services? What's your cost structure? Do you know what it costs to put that box of food together? Do you know what it costs to hold this behavioral health support system and peers and all of that? I know that that's challenging, but it's a necessary part of understanding how you price your services moving forward. This is talking to the social care providers and the behavioral health providers. What do you do to keep people out of the hospital, to improve health outcomes, and to improve the well-being of your population? And then start to understand how what you do translates into what value-based payment, fee schedule, reimbursement models that might be piloted in this waiver. All right, so what happens next? This is a high-level timeline. So September 2nd, the waiver was submitted to CMS. CMS deemed it complete, which is what Wade meant when he said accepted. That was on September 15th. The comment period is now open. I think, Albert, when we send a follow-up email, let's include the link to that federal comment. That's open till October 19th. There will be a September 28th New York State Public Forum. That is on the overall 1115 waiver, not specific to this, but overall. And there's a lot of different aspects to the 1115 waiver, not related to this demonstration project, but I would suggest that you have somebody on that call to listen in and perhaps ask questions and do public comment if you'd like. So that's another opportunity. The contract negotiations will then start between CMS and New York State. The state or the federal government will be looking to make sure that feedback has been incorporated by the state. And then they're looking for this target date of January 1st. Now, when we would get the notification around, where the state and the federal government landed, maybe November, I don't know. So that brings us then to our timeline. We will on Monday put out a site where all of the materials are going to be collated, the community forums, the actual link to the waiver, federal comment period, as well as the recordings, the FAQs, and then we'll start to build out that kind of central place for people to go to and for you to share around as appropriate. We will continue advocacy specifically on the geographic region. I do know that there is a sense that the CBO space still has room for improvement. And I would highly, highly suggest that you connect with your CBO partners and your CBO infrastructure support mechanisms and agree on how you would like to approach the state or the federal government around your concerns, around meaningful engagement in this waiver, and how the funds are going to flow, and how is the state going to ensure that the CBOs are not cut out. I would highly recommend that. Next forum, we're thinking early December. We might change that depending on if new information is available. And so it'll be maybe a combo of email updates pointing you to this section of kind of this repository of information and or another forum. Okay, so 12:42, I think I probably went 10 minutes over where Albert and Wade wanted me to, but we can open up for discussion and Q&A, and maybe we can kind of see everybody again.
Carol, if you stop sharing your screen, I'll.
I didn't realize. Okay, that's in my control. Okay, of course. All right, here we are. So good to see everybody.
Absolutely. There are a couple of questions in the chat as you were presenting, Carol. I think the first one that I saw was a question about whether or not the state is going to be setting the rates for the community-based organizations under a fee-for-service model.
Somebody correct me if I'm wrong. I don't think so. Albert, Wade, what do you think?
I don't think so either.
No, I don't believe that that's the plan.
So really quickly, this is Corinda. That was my question. This is not a space that CBOs typically work in. And I know when I was in the aging network, there was a lot of difficulty with rate setting, especially in the area of Medicaid. How will the CBOs be informed and or trained in how to do that rate setting for themselves?
Yeah, so that is the purpose of the Social Determinant of Health Network. They will be the support mechanism. It's a network of CBOs. So that infrastructure will be the support mechanism to do capacity building for CBOs, education, training. This is where the SDHN infrastructure would partner with organizations like United Way and Council of Agency Executives and other like organizations. As it relates to rate setting, that is obviously, this is why I say it's so important to understand your cost structure. What are those services? What are the elements of those services? What it costs you? And then there's going to have to be a concerted effort to start to build out that fee schedule at the SDHN level, and then translate that into discussions and negotiations with the IPAs who are under VBP arrangements and or the managed care organizations. I'd love for anybody else to comment on what I just said. So can people get unmuted? Albert, do we have to unmute people, or how are we doing that in case somebody wants to add something to what I just said? Okay.
No, Carol, there is one other question from the chat as we went, but I think it's one of those questions that we're going to have to look into and get back with regards to a 4% sequester cut back from 2010. But I do see a couple of people with their hands up. So As I indicated, if we're not able to get to everybody's questions, please do drop them in the chat, and our aim will be to get out responses in the follow-up to this meeting. But Laura, do you want to chime in?
Yeah, I just have a comment. I know for some, particularly like the prep for VBP notes might feel intimidating. I would just note that even when the last waiver was underway, we knew this moment in time was going to come. And that's part of the reason we've done the work under systems integration and created tools that help us gather business intelligence to do that type of analysis. And so it's okay if you don't have those tools in place today. Know that those tools have been developed with providers and communities, and there's time and opportunity for you to join a network, to implement tools, and to begin practicing how to use those tools so you can get to that. So I just want to note, we recognize that that is not easy for folks today. And yet we've spent a lot of time over the last 5 years thinking about how that is possible, building what needs to be built to allow that to happen, and implementation is underway. So there's just real opportunity to start that journey, and that you don't have to be at the finish line right now.
That was very well said, Laura. Thank you. Excellent.
Thanks, Laura. So I have Anne-Marie Cook, and then Dr. Kazarowski, and then Stephen Harvey. Go ahead, Anne-Marie.
Yeah, thank you. Wade and Carol, on page 26 of the waiver document, the last paragraph, I just want to read one sentence to you, more so to get everyone thinking about this. It's in reference to VBP, and it says the MCOs will be encouraged to contract with safety net hospitals, clinicals, social determinants of health networks, yada, yada. The word encouraged honestly sent me through the roof a little bit, because I thought that's not strong enough. And so I don't know if you want to comment, but I just want all of us to be aware that I think that word needs to be stronger than encouraged to contract with all of us. And instead really give preference that they must contract with all of us in the community to work on social determinants of health.
Yes, so Anne-Marie, thank you for bringing that up. It's like we planned it. So that's exactly what I was referencing when I said that it's going to be important for the CBOs to come together, look at that language, and really rally around accountability at the state level for what exactly you just said. I am very concerned with that word encourage as well. The question is, how are you going to encourage? Can you change the language? If you change the language, what does that mean? And what are the mechanisms that you're going to use to incent and or penalize? I don't like the word penalize, but how are you going to make sure this happens? Because frankly, if that is not addressed / resolved, this entire waiver won't mean anything.
Yeah, and
I'll just, if I can just jump in and say as a punctuation, this waiver is still being developed. And after the FADS Act, and stepping on Carol's sermon, there's a state regulatory, statutory, and budgetary action that's going to really allow us to see what the program is. I absolutely believe that holding the issue of this language is just as critical for us as the language around geography, because our reality is we have two not-for-profit regional insurers who are leaning forward, Excellus and MVP Healthcare. They don't have all of our market. There are other insurers who are active in our market and are not leaning forward, and traditionally have not leaned forward and have growing shares of the market. I think it is going to be very important that we make sure that we are skating not towards where the puck is, but where the puck is going. And dealing with that language is a very important thing. And that's why, friends, our collective wisdom is a hell of a lot greater than our individual wisdom. And so remember, every time we're saying, ouch, What we're really doing is surfacing, here are pain points, so that we can figure out how to collectively engage around those pain points in a way that takes us not just where the state of New York wants to go, but takes us also, and more importantly, to where we know we need to go. So thank you. And I just wanted to round that out with whatever, if that's a period, a question mark, or an exclamation point, or a set of ellipses, as Albert tells me I often provide. Please, thank you for letting me give that punctuation.
Thanks, Wade. Before we move to Dr. Kazarowski, I did see that Melissa Gardner was on and was about to unmute. So I just wanted to give her an opportunity to chime in specifically on this before we keep moving.
Yeah, the role of being a managed care organization is helpful here. All I wanted to share with you is from Excellus's view, we're aligned in the mission and the need of the connectivity and the multi-stakeholder. So those words don't worry me from obligations of Excellus. Wade, you actually hit it perfectly. They could have unintended consequences, though, when spread against other insurers who have just enough engagement and influence in our communities that could rock the boat. So I wasn't even going to bring that up because the key point is Excellus is aligned. Excellus wants to make those contracts happen. We believe in the Medicaid vision, and you can trust that. We all do need to balance the fact that a requirement could make some of our lives difficult, more difficult. So let's balance as we think through language.
Thank you so much, Melissa. All right, so I have Dr. Kazarowski, Stephen Harvey, and Jen, and I think we're going to close off the comment period with Jen, and then move to close the meeting. But I'll just reiterate one more time. Any questions, comments, anything, please drop it in the chat, and we'll work to follow up.
Thank you, Albert. Thank you, Carol and Wade. We're excited to see progress that children and women and families are now in the waiver. And that's a great credit to you and your leadership here. And it's still not enough. And I want to say last time we had a waiver, Carol knows this well, only 2 out of 25 of the PPSs made any significant investments in women and children's health. And we here at Flips and with Common Ground leading, we're one of them. But 95% of the PPSs made no investments in women or children. And so we would like to ask that you join us in some advocacy to CMS and to the state to require investments in kids. I'll just say a couple of words as to why, other than that glaring omission. One is, if you listen to both of Wade and Carol's stories today, they were both about kids. The invisible child and Wade's mom moving to change the education environment for her young family. Second is, 50% of kids are on Medicaid in New York State. 60% of young kids. Medicaid is the lead insurer for kids in New York State. If Medicaid doesn't change, nothing will change for our most vulnerable kids and families. And then the last thing is, in a waiver focused on equity, kids are the poorest and most diverse segment of our population. Black moms die at 5 times the rate of white moms in New York State. Infants, Black infants die at twice the rate of white infants in New York State. But waiver is going to be focused on equity. It has to address those things. So really appreciate all the effort. And I feel like we've made tremendous progress and we still have a ways to go, and would love the work of this group, Wade and Carol, and your leadership here, which is really leading the state to be involved in that effort. Thank you.
Thank you, Jeff. Mr. Harvey?
Hi, thank you. First of all, outstanding presentation today. So I just want to make sure I'm understanding this correctly. For social determinants of health referral platforms like UniteUs, from the way I read it and from what I heard today, it seems like networks can go ahead and contract with one of those platforms as long as those platforms can guarantee that they're interoperable and that they can do a data dump to Shiny. Is that correct? Or your impression?
Any network, right, any social care platform needs to be qualified by New York State, and they're going to have a rubric, obviously, for interoperability. Somebody can correct me if they know. I don't think we have the timeline on that yet. Laura, do you have that? No. Okay.
No, not yet.
So is that
So-
something that we can move? We can move on, you think?
Yeah, so what I would suggest, and I noticed in the chat here, a lot of people are asking, the CBOs are asking, what should I do next? Specifically, what should I do next? I highly suggest you continue to talk with and engage with your networks. Together Now, 360 Network being kind of the most adopted right now. FLIPA, obviously, with the behavioral health providers and a couple of the CBOs. Those are the networks that are going to be supporting you through this process.
Thank you.
Thank you, Stephen. And our last commenter, Jen.
Good afternoon, everyone. Thank you, Carol, and everyone here. I just wanted to make a few comments. It's Jen Carlson with FLACRA. A couple of things. I know MHA put out an example of rates for social determinant of health companies probably about 3 months ago or so. So I don't know, Carol, if you did get a hold of those or if they had floated through this group, but I just think it'd be a great spot to look at. I'm sure there were examples, but I think it's just helpful for people to kind of really dig down after we know more questions to ask, then we seek more answers. And I think it would just be a great idea. So if you don't have those, I can sure forward those to you, Carol or Wade. And then, yeah. And then I think just secondly, I really love the zeroing in on the health plans. I think that though respectfully hearing today, I think Excelis has been a great partner. I'm just going to speak for FLACRA alone. I can't speak for everyone, of course. I do think that among most of the state organizations, there is a lot of concern around the specific or lack of, as Anne Marie is stating, it is a concern. I think anytime there's language written so loosely, I think it's concern for everyone, I think equally and fairly. So I would, again, second that opinion, if that is what Anne Marie indeed was saying, is I think it's an area of public comment for this group about what, and I'm not even saying what, but I think the strengthening of it somehow. And I sure know that most of the networks and advocacy and policy influencing groups I'm on will be making comment around that, because it's honestly, I think as Carol, you may have said, if we can't figure that out, we've got really nothing else to do after, because the way that will move, it's the beginning flow. And so it really does need, I think, a lot of focus. And I just wanted to add that. And I couldn't say anything wiser or more eloquently to the gentleman that spoke to before me about children and families. I'd take those statistics, I'd add in invisible disabilities and policy making around education. And I do think it's some of the work that a regional planning forum such as this has opportunity to do. So at any point in time, if any others are interested in really thinking about some of those statistics together, I would ask us to think about, yes, the Black child, the female not getting the health care they need prior, the 1 and 3 children that will lose a parent before the age of 18 to overdose. And let's put a lot of those statistics together. And I think there's a lot of work to be done. And we think we can do some of it right through these groups forming. Thank you.
Thank you, Jen. So I know a lot of people are having questions about, what to do next. Definitely connect with whatever natural networks you connect with, and your support system. So your United Ways, like I said, Together Now, 360, your FLIPA, your IPAs. Also, CCSI has been an incredible partner in this, and I thank them for helping me put together this slide deck. Ian Wilder and I many late nights on this kind of stuff. So whoever your natural kind of support systems are, as well as coming to me and Wade. And again, we're going to be happy to do similar presentations. Of course, we would customize them depending on who the audience is. It's hard to kind of figure out the focus when you've got a big group, but we want at least everybody together, like this for like the general information. We will be on Monday sending out the link to kind of like where all the documents, the FAQs, also what the federal comment period or the federal comment link is for written, as well as the dates, the important dates. So hopefully that will be helpful. This is, again, just the third forum. We've got a lot of work to do. We have a lot of more information to share. For now, talk with your networks, listen to your association presentations and your kind of natural gatherings. And we're really excited to be partnering across the community. Back to you, Wade. Send us off.
I will send us off. Friends, thank you. I know how busy my life is at every moment, and I appreciate how busy your lives are. Thank you for being here. This is that challenging moment I've been talking about since the spring of being in a liminal space. That space between what was and what is to be. And we are fast approaching opening the door of that liminal space and moving in to the next. What I would ask you to do, because this is still a thing in process of being, and because this is a thing we have never done before, as we prepare for next forums and for information flows to be responsive to what you said, as we think about a strategy, and Larry Marks, thank you for your comment of the children's agenda, mobilizing. Let us make sure we're coordinated. But what I would ask you is to be very, very present of the policy question, which is how much of what we aim for are we seeking to win at the state level? Where at the state level, the interests of New York City mean a hell of a lot more than our interests. So as we seek to be influential at the state level, we really need to think about how to be influential at the upstate level. And how much of this do we want determined by how the regional operation occurs? I want to leave you with the thought that I'm not looking for the state to be so much as directive of what we do, as I'm looking for the state to not be prohibitive to what we do. And I want to confess that I come to that because of my lived experience. I've spent my entire adult life in the world of how does a bill become a law in Albany. And so to the man who hammers well, the whole world is a nail. But as you all know by the work you do, the world is not simply a nail. It's a screw, it's a clasp, it's a button, it's a zipper. It is all of that which we do collectively, and it cannot afford to try and be condensed down to my truth is the truth. And so I promise you, although I come with strong opinions, I am going to continue to be a listener of the symphony, not the guy who thinks he's the violin section and the string section and the horn and brass section. And I promise you the same thing for which I am grateful, that you allow me to come to this work authentically. As someone with a child who died at birth, I'm very sensitive to the reality of my wife among all women should never have had not only the loss of a baby, but her own life in jeopardy in the summer of 1992. And if you wonder why I operate the way I do, it's because of the fact that I said on that day, and me and mommy talked about it yesterday, Lord, if you spare Lisa, I will never complain about a goddamn thing again. My radical optimism, my ruthless enthusiasm for community comes from the fact that I know what brought me down this long and winding road. It wasn't just my relatives, and it wasn't just my church. It was many of you and so many of the organizations that you represent. That is what still brings me here to this door. And thank you for having answered when we knocked on it. We're going to be back to you. We're going to be in continuous conversation with you, and we're going to continue to win this city back for our children. And we're going to win the Finger Lakes region back to its heritage as the place where freedom is perfected and where marginalized people know this is where you can go and be cared for. God bless you all. Thank you so very much. Have a wonderful weekend.